Hello, my name is Yolande Lievens. I'm radiation oncologist, chair of the radiation oncology department at Ghent University Hospital in Belgium. And it's my pleasure to be with you today to discuss oligometastatic disease, definitions and practice patterns. I do not have any conflicts of interest in respect of this presentation. You all know, obviously, that the concept of oligometastatic disease has been defined as an intermediate state between localized disease and systemic disease, and that the interest for oligometastatic disease is related to the fact that we think that cure may be achievable with local treatment. It is already more than 25 years ago that actually Hellman and Weichselbaum have published a seminal paper on defining oligometastatic disease. And it took quite a while before some evidence from clinical practice started to arise. As you can see on this figure, it's only about the last 10 years that data on metastasis-directed radiotherapy started to arise in the literature. And what you also see is that while the vast majority is related to retrospective studies, either single center or multi-center, that the prospective series are really in the minority, and that the same holds for phase 1 or phase 2 and phase 2 randomized trials. So as a matter of fact, at this moment, we do not have any level 1 evidence on metastasis-directed radiotherapy, but we do have several randomized controlled phase 2 trials that you can see depicted here on the table. 3 of these are performed in non-small cell lung cancer. 1 was in colorectal liver metastases. 2 trials focused on prostate cancer, and 1 trial was focusing on metastatic disease from a different range of primary tumors. And although some of the studies are very small, you can see that all reported a significant and clinically relevant benefit of metastasis-directed radiotherapy, at least in terms of progression-free survival, but for 4 out of them, it also translated in an overall survival benefit. But the problem we have with these small studies, and in the context of a multidisciplinary treatment strategy that is continuously changing, is that, well, indeed, radiation techniques and technologies change, but in the same time, also surgical techniques evolve. And I will not have to convince you that also systemic treatment strategies are continuously changing with new drugs coming onto the market, adding potential beneficial therapies for these type of patients. On top of that, we have changing imaging modalities that give us another approach to the patient population that we see and may change the disease presentation. So it's difficult to generate evidence on all the patients that we know. And actually, it's also important to understand that although there's a biological rationale for oligometastatic disease, there's no validated molecular biomarkers at this moment. So what we know about oligometastatic disease is currently really an imaging-defined diagnosis. And that's why the EORTC, the European Organization of Research and Treatment of Cancer, has been devoted a few publications on defining how this imaging should be performed. And if we look at breast cancer, then you can see for the EORTC, while they advocate to use conventional staging imaging for routine practice, but also a diagnosis to add FDG PET-CT scan, and that if there's any suspicion on neurologic symptoms or anything on the standard imaging that would suggest brain mets, then an MRI of the brain is also necessary. In addition, an FDG PET-CT scan in presence of suspicious lesions on surveillance imaging is necessary. And on top of that, if the primary clinical question is to detect or exclude liver mets, then an MRI of the liver should be performed. In addition, whole body MRI or PET MRI may be of added value if these are anyhow available, but the latter are not standardized. I would also like to point your attention to the fact that also ESMO and NCCN have defined guidelines that, while by and large, go in the same direction. But the only thing that I would like to mention that NCCN also points out that on top of the imaging, it should be tried to have biopsy confirmation if lesions are equivocal on FDG PET-CT scan. And with all this, I would like to refer you to a painter, which is well known, Belgian painter, who's called René Magritte, and he painted this picture of a pipe, and he said, well, this is not a pipe. Of course it's not, it's a picture of a pipe. And I think this is very well applicable also to the fact of oligometastatic disease, because what we see is not per se oligometastatic disease, it's what we can understand as oligometastatic disease on the basis of the images that we see. So from that point of view, the EORTC, together with ESTRO, the European Society for Radiotherapy and Oncology, have taken up the challenge to develop a consensus nomenclature and comprehensive system for oligometastatic disease characterization and classification in order to get a better grasp of what the whole well, different nature of oligometastatic disease could be that we see through the images. And together with a group of experts, a decision tree approach was developed in which there were 5 key questions. And by applying this and confirming this in the Delphi process, 9 different states of oligometastatic disease have been defined. And actually, they are centered around the fact that oligomets may be de novo, and then we mean that they arise synchronously or may arise metachronously in a patient, so after a disease-free interval. They may also be repeat. That means that there was a prior history of oligometastatic disease that has been addressed with treatment, or they are induced. And that means that a prior history of polymetastatic disease is present, but that with systemic treatment agents, well, a majority of these lesions have disappeared or are not active. And so we now see a oligometastatic appearance of this previously polymetastatic disease. On top of that, we have also defined oligorecurrence, which means that the patient is systemic therapy free at the moment. Either it can be oligoprogression, which means that the patient is progressing under systemic therapy, or there can also be oligopersistence. That means that there was already oligometastatic disease, that treatment was given, and that there's no progression, but these lesions remain present, and therefore we define them as oligopersistence. And if you put this all together, well, then you can find 9 different states of oligometastases, which have been defined in much detail in the paper, and I warmly invite you to take a look at this paper. Of course, this is a construction that has been made and that has to be validated in clinical practice. And the first approach or attempt to do that was done in the group of Matthias Guckenberger, who was also the first author of the paper. And he looked into his department and in patients, 389 patients that were treated with maximum 5 metastases. And what you can see in this very initial analysis is that de novo and repeat OMD do much better in terms of overall survival than do induced oligomets. And this is probably also quite logical if you think about the fact that the latter are actually arising from polymetastatic disease. But this is only a first approach in clinical practice, so we need much more data to validate this definition and categorization. And that's why, in the context of a collaboration again with EORTC and ESTRO, there was an attempt to collect these data for oligometastatic disease in the context of a broader platform, in the context of the radiotherapy infrastructure for Europe, which is actually an infrastructure that allows to do observational prospective multi-cohort studies that collects real-world data of cancer patients treated with radiotherapy. It's an overarching infrastructure, so that means that there's only one database, one protocol, and one patient-informed consent. So if a patient goes to different cohorts, it's only once that he has to consent. And thus linking between clinical data with diagnostic imaging and also with radiotherapy treatment imaging is possible, also with patient-reported outcomes and health economic data. So why would we collect real-world evidence in oligometastatic disease? Well, I have already alluded to the continuous changes that occur in radiotherapy technologies and techniques. And moreover, we know that beyond the improved outcome that we try to achieve with radiotherapy, we also know that there's a decreased long-term side effects that we try to achieve with better treatment and better treatment indications. And all these aspects can be difficult to generate within clinical trials alone. This may be unachievable, or it may be too long to gather all these data. So we think that not all clinical questions can be answered through clinical trials alone, and that we need a mixed approach to data generation, including prospective data registries with real-world data. And so this is what the goal is of E2 Radiate, where the collection of real-world data of cancer patients treated with radiotherapy is the focus. It wants to provide evidence on the role of radiotherapy in a multidisciplinary approach, support radiotherapy research, and generate hypotheses for further clinical trials where we have to focus on very distinct tumor or patient entities. So at this moment, there are 3 cohorts that are being active or being elaborated. It's OligoCare for oligometastatic disease, particle care for particles, and ReCare is being started for re-irradiation. All cohorts have minimum inclusion criteria. Obviously, the patient has to be confirmed to have cancer. There should be a planning of radiotherapy, and eligibility for at least one of the cohorts should be confirmed, and the patient should be older than 12 years old. For each cohort, additional selection criteria can apply, and for each cohort, one of the following endpoints applies. By and large, there's a lot of clinical outcomes that are recorded, but on top of that, there's also a focus on quality assurance of radiotherapy, patient-reported outcomes, and economic impact of the radiation treatment. So OligoCare is the first cohort that was active. It's a pragmatic observational cohort study to evaluate radical radiotherapy for oligometastatic disease. The objective is to identify patient tumor diagnostic and treatment characteristics, influencing safety and efficacy, and evaluating patterns of care and patterns of outcome. The primary diseases that are allowed within this cohort are lung, breast, prostate, and colorectal cancer, but there's no upper limit of the metastases that we allow to include, as long as all are treated with radical intent, and at least of these one is irradiated with radiotherapy. And we did so because if we would not, then we would not see what is really happening in clinical practice, and we would not also know whether these patients with more than 5 metastases, for example, would have benefit. It's a very lively research collaboration that started more than 2 years ago now. You can see the countries that have been enrolled so far in 37 sites. And we hope that by the end of 21, we will have one additional country enrolled, and that 21 sites will be activated. But the next phase of site activation is planned for the first part of 2022. So it's a continuously growing group of people collaborating. You can see the accrual on the figure. The first patient was enrolled in August 2019. And while what you see is that while there was a quite slower uptake in the beginning, it was also a bit hampered by COVID, as you may understand. But at the moment, we are at a continuous rate of about 50 to 60 patients on a monthly basis. There are not many data evaluated so far, but these are the data that were presented at the recent ESTRO conference. So what you see is that in the 395 first irradiated lesions that were evaluated, well, they received fractionation schedules with 3 or 5 fractions and a median fractionation dose of about 10 gray, which is in line with what we expect in the literature, and a biologically effective dose that is a median of 74 gray. If we try to categorize these lesions to the different categories that we've discussed before, then you see that the vast majority of patients are really in the oligo-recurrent setting. And if we look specifically for breast cancer, then you see that this population is not dominant at this moment, maybe a bit more prominent in the metachronous oligo progression. Another example of real practice data collection is the data collection that we did in Belgium. And this was a collaboration of the clinicians with the reimbursement system, with the Knowledge Center in Belgium, and with the Cancer Registry. And actually, the context was that there was no SBRT reimbursement in Belgium, and that we wanted to elaborate on that. And we started a coverage with evidence development program that was based on recommendations from the Knowledge Center that said we should have registration of innovative radiotherapy to collect data on indications and technical characteristics of the treatments that we deliver, and that we should map the diffusion and monitor the safety and the effectiveness in real practice. So all centers that wanted to receive financing for treating patients with SBRT had to sign an agreement with the compulsory health insurance, and it was planned to have a registration for over a period of 4 years, but it was expanded to 5 years in the first round before analysis took place. It was based on SBRT and accelerated partial breast, but for the rest there were predefined target populations, but no minimum criteria for patient selection. So, for example, there was no exclusion of WHO patients with bad performance status, because again, we wanted to capture what was happening in real practice. And the registration went through the clinical, module of the Belgian Cancer Registry. Further inclusion of the collection was performed until the end of 2020, until the end of 2019, because in 2020, on the basis of the first analysis, we had the installment of SBRT in the reimbursement system. So the SBRT indications that were defined for oligometastatic disease were up to 3 lesions, and it was defined that hepatic metastases, paraspinal metastases, and lung metastases were sufficiently considered standard of care to be allowed like that in the registry, but non-standard oligometastatic disease, which were other indications, need to also be enrolled in a formal clinical study. So I can show you a few data on the initial analysis of the data collection until the end of 2019. In total, 20 centers of the 25 accredited Belgian radiation oncology centers participated over the course of the registration. And over 5,600 SBRT courses were withheld for analysis, of which about half were of primary tumors, mainly lung cancer, and the other half were metastases, of which again half were on lung lesions, then paraspinal lesions and liver lesions followed, and non-standard metastases were 16%, and they were mostly lymph node metastases and non-paraspinal bones. There was a collection of patient characteristics, tumor characteristics, treatment characteristics, and outcome was also registered in terms of survival. And link with administrative data sets is feasible, but has not been performed as yet. You can see some data here at this moment. So 2,790 SBRT cases were available for analysis. You can see that in clinical practice, there was a very good selection actually of the patients, in the sense that the patients had the better WHO status, with 80%, over 80% having at least a WHO status of 1. And the average number of lesions that the patient had to treat was 1.22. So the majority had limited oligometastatic disease. The most frequent tumor types were colorectal, prostate, lung, and breast only had 9% of the indications. And the lesion sizes of the metastases were somewhat smaller for lung, with an average of 17 millimeters, where it was more or less 30 millimeters for the other lesions on average. And you see on the right side, but this only pertains to, on the right side of the figure, you see data that only pertain to the 1,468 first patients that were analyzed by the end of 2017. And you see here that the patients with prostate cancer did best. Those with lung cancer did worst in terms of overall survival, and breast cancer was somewhat intermediate together with colorectal primary tumors. So another approach, or another series of real-life data, was published recently by the United Kingdom, where there was also a question of SABCS not being reimbursed for oligometastatic disease, and they started a commissioning with through evaluation program, where they funded extracranial oligometastatic cancer to access as SABR within the NHS in a prospective registry-based single-arm observational evaluation study. And 17 NHS radiotherapy centers in England participated, mainly big centers, mainly academic centers. The selection criteria were somewhat more stringent. 1 to 3 extracranial metastatic lesions were allowed. Disease-free interval had to be there of at least 6 months, except for synchronous colorectal liver mets. W performance status should be 2 or lower, and life expectancy should be expected of at least 6 months. And data were collected between June 2015 and January 2019. And after that, actually, SABR was commissioned for oligometastatic disease by NHS England in March of last year. Some of the data, you can see that again, the WHO performance status is pretty good, with over 90% of having at least a WHO of 1. Dominant were prostate and colorectal cancer, with lung cancer being much less frequent here, but breast cancer also only being 5% of the population. You see that lung metastases were also frequent in this cohort, but lymph node metastases were even much more frequent than compared, for example, to the Belgian case. And again, the number of metastatic lesions per patient were dominantly only 1. So the major patients only had a limited number of metastases. And if you look at the overall survival data, then you can see that they are very good, as well as local control data. And on the other hand, adverse events were very limited, with almost no grade 3 or 4 and no grade 5 toxicities. What they found was also that prostate, breast, renal, and colon cancer did better in terms of survival for the oligometastatic states than lung cancer. So if you compare the different patterns of care studies that we have ongoing now, you see that the participation is somewhat different, with a broader representation in Belgium of all types of centers, more academic in England, and 37 centers across Europe, also a mixture of academic and smaller centers. The indication is more restrictive in OligoCare, in the sense that it's only certain primary tumors that are accepted, but in England and Belgium, it's only extracranial metastases. The evidence generated is less granular in Belgium, because there's no capture of local control and toxicity, as was done in England, but in OligoCare, there's a very granular data capture on outcome. The incentive for data collection was similar in England and in Belgium, in that there was no reimbursement for SBRT, either as a whole or only for oligometastatic disease. And in OligoCare, it's really a research question to try to observe patterns of care and patterns of outcome to support further clinical trials. And as you can see, the overall survival data are pretty good, hovering between 85 and 90% at 1 year and 70 to 90% at 2 years. So this brings us back to the definition of oligometastatic disease. And this is a very busy slide that comes from a publication that we have been doing, radiation oncology experts from Europe and the US together. And this is a representation of what we found in terms of definitions of oligometastatic disease in the literature. And actually, it's a very heterogeneous definition. So what we found in this work is that the available evidence on use of metastasis-directed radiotherapy for oligometastatic disease is mostly retrospective, single-center series, and there's a significant heterogeneity in inclusion criteria in the definition of oligometastatic disease and in the outcomes. But together with our group, we have made a consensus on different key questions. We defined that oligometastatic disease is independent of the primary tumor, the metastatic location, or the presence of length of a disease-free interval. So both synchronous and metachronous oligometastatic disease is recognized, and systemic therapy-induced oligometastatic disease is a distinct state of oligometastatic disease. The ability to deliver safe and clinically meaningful radiotherapy with curative intent to all metastatic sites is really a minimum requirement for defining oligometastatic disease in the context of radiotherapy. We do need high resolution imaging to assess and confirm OMD, and including brain imaging if this is indicated. And we also supported that the common endpoints such as progression-free survival, overall survival, local control and toxicity and quality of life should obviously be reported, but also that uncommon endpoints such as deferral of systemic therapy and cost should be endorsed. So all in all, we can state that at this moment, from a pragmatic approach, oligometastatic disease can today be defined as 1 to 5 metastatic lesions, a controlled primary tumor being optional, but where all metastatic sites must be safely treatable. And with this, I thank you very much for your attention, and I'm looking forward to this discussion in the panel. Thank you so much.